stereotactic radiation, which leads us to William Chu, who is a radiation oncologist at Sunnybrook. Stereotactic radiation. I went for that in 2008 here, actually, in Toronto, Princess Margaret, and the tumor has been stable ever since, and basically, as I said, we have NED, but it is a tremendous advancement in kidney cancer care, and William Chu is going to come up now and tell you about it.
Good morning. I just want to extend my gratitude and thanks for the invitation and opportunity from Kidney Cancer Canada to speak to you today about some of the exciting things happening in the field of radiation oncology, in particular the emerging and evolving role of stereotactic radiotherapy in the treatment and management of patients with renal cell carcinoma. Oops. So as you heard earlier from Dr. Finelli, surgery remains the mainstay, backbone, gold standard primary treatment for the management of renal cell cancers in fit patients. The issue then becomes, though, in those individuals who have enlarging lesions roughly between 3 to 4 centimeters, that are demonstrating a growth rate but yet have serious medical comorbidities that make them ineligible or unsafe to have that surgery. For example, other patients may have risk of having dialysis after surgery, as you heard about earlier, or those individuals who have a single kidney, or for those individual patients who decline surgery or decline a surveillance protocol. What do we have to offer them? Traditionally, as I mentioned, there's surveillance. You follow and watch and observe and only intervene if there's an increase in rate of change and growth. And traditionally and historically, there have been minimally invasive ablative procedures such as radiofrequency ablation and cryotherapy. I'll briefly describe these for you here. Radiofrequency ablation has been a long and trusted and true interventional radiologic procedure which requires either local anesthetic or an IV sedation, inserting the probe or catheter directly through the skin under direct visualization, as you can see here, generally under CT image guidance, by placing the probe directly into the tumor and then passing higher energy radiofrequency waves, or in the more recent evolution, microwaves to actually burn and ablate the renal tumor. Very successful, over 90% success in controlling the tumors that are less than 3 centimeters in size, and not a very high complication rate, anywhere from minor to moderate side effects in about 1 in 5 patients who have this procedure. It's widely clinical available, and there's lots of individuals who are very adept at doing this procedure. Cryotherapy, on the other hand, is not that widely available. There's limited clinical experience, but once again, it requires either local anesthetic, either through a percutaneous approach or a laparoscopic approach to insert these catheters or probes directly into the tumor. Then liquid nitrogen and liquid argon is then infused to create freezing and thawing cycles that essentially damages and kills off the renal tumor itself directly in the kidney. Once again, excellent control rates in reported literature to date, about 90% in tumors that are less than or equal to 3 centimeters in size. And once again, there's about a 20% chance of complications ranging from minor to severe, such as bleeding. Radiation and renal cell carcinoma. Historically, renal cell tumors have always been thought, and I learned in textbooks and from my mentors and my teachers, that that is a radiation-resistant tumor, i.e., it does not respond, it does not die to standard doses of fractionated radiation, mainly low doses of radiation delivered in small doses, anywhere from 1 to 2 gray, that's the unit of radiation, typically over 5 to 6 weeks, really had little effect in killing kidney cancer. However, in the laboratory, preclinically and clinically, we see an excellent response, a high volume of cell kill when you have radiation doses delivered at 3 times or more than the conventional doses of radiation that we did previously. In preclinical models and in the laboratory, we've been able to see that we can deliver single shots of whopping doses of 24 gray effectively and safely. And as you heard about earlier, in the literature, as well as in our own patient clinical experiences, that stereotactic radiosurgery, particularly to tumors that have traveled to the brain or to the spine, result in excellent control, over 90% for a number of years. So what is stereotactic body radiotherapy, or SBRT, or what you may hear in the literature or what people describe as SABR, or stereotactic ablative radiotherapy? It's defined as the precise delivery of ultra-high doses of radiation to targets outside of the brain or other body targets, typically done within 3 to 5 treatments, which can be accomplished within 7 to 10 days, or a week and a half. The key to this is the precise and accurate delivery, but also the highly conformal or sculpted radiation just to the tumor, to the target itself. We at Sunnybrook have experience delivering that to the spine, as you see, to the lung, and to the liver, in addition to the tumors of the brain. Stereotactic body radiotherapy at Sunnybrook has been up and running for almost a decade, and as we've been gaining a wider clinical experience and comfort level, we've expanded the indications to treat tumors that have traveled to other parts of the body. If you exclude treatment of radiosurgery to brain metastases, between 2012 and 2013, we treated over 600 cases of body targets that included the spine, the lung, the liver, and the prostate for both primary and metastatic tumors. So the evolution to treating renal cell carcinoma was actually a natural progression and moved for a clinical program. So stereotactic radiation for renal cell carcinoma. What are the indications from a tumor characteristics and from patient characteristics? Tumors generally less than centimeters, 7 centimeters in size, but generally who are growing on surveillance at least 3 to 4 centimeters. So in between that range, 3 to 4 to less than 7 is a typical range we offer. The key to radiation or stereotactic radiotherapy in comparison to radiofrequency ablation or cryotherapy is that, like in real estate, location, it doesn't matter for us. For radiofrequency ablation and cryotherapy, generally it's peripherally located tumors on the outside of the kidney, because the procedure itself carries a higher risk of complications if it's close to the blood vessels or to the collecting system of the urine within the kidney. For radiation, stereotactic radiation, it doesn't matter. We offer treatment both to the periphery and to centrally located lesions. The patients that we offer treatment to are those who, once again, are not operative candidates or who have declined surgery, or individuals who are not safe to undergo anesthesia. And we offer it as primary treatment or also in the oligometastatic setting that I'll mention a little bit later. So this is a very busy slide. What it's there to do is to illustrate to you there is a growing body of literature and evidence of stereotactic radiotherapy for the treatment of renal cell carcinoma, both in Canada and worldwide. Take-home message is that the most common treatment regimen requires 5 treatments, typically done over 10 days. The control rate is excellent, measured at 2 years at over 90%. And the side effects or toxicity, which generally includes fatigue, nausea, and occasional flank pain, the majority of the side effects are mild. There's very little moderate side effects and very few, if any, rare, serious side effects from stereotactic radiation. And once again, the key to this, as I mentioned, as you see in the bottom, is that there is no restriction really on size or location for us to deliver a course of stereotactic radiotherapy. So what are the 4 key tenets or pillars for us to deliver stereotactic radiation successfully? First and foremost, we must be able to see and identify the tumor target. Secondly, we must be able to limit and integrate within our treatment plan normal body tissue or organ motion. As we breathe, the diaphragm moves, and so does every internal organ within our body. Thirdly, our ability to calculate highly sculpted doses of radiation to the targets that we define, but also the technology, hardware, and software to actually deliver that highly precise course of radiation to the patient on the treatment bed. And then at the time, we must be able to see and manage the motion right at the time of treatment delivery. So those are the 4 key tenets, and I'll illustrate them for you. So, target identification. We use the latest imaging technologies available to us, contrast-enhanced CT scans, in addition to MRI, to basically clearly identify the target. As you see here on your left side of the screen, that is an axial cross-section of an individual with a tumor highlighted by the red arrow. The center picture is that person's visual seen face on. We then define that tumor within our treatment planning with a sculpted target, as you see on the right side of your screen. These image sets are then fused to allow the radiation oncologist like myself to then outline, or what we call contour, and define the target. Managing organ motion. Unfortunately, the movie doesn't work, but this cross-sectional image, as well as a coronal or head-on image, was meant to illustrate to you that as you breathe, there is excursion of the kidney and the tumor and the kidney tumor seen on the right. Across different patients, the magnitude of that motion can vary anywhere from about 5 millimeters to 15 millimeters. And the interesting thing is that it's not linear. It's not straight up and down. It's a component of both up and down, front to back, and sometimes even side to side. So how do we mitigate that in our treatment plan? Well, when the patient comes for a radiation planning, we make them a customized vacuum cushion. We mark them with a tattoo, but then we want to minimize their breathing by putting them underneath a plastic top sheet or vacuum compression. It's about 100 pounds of pressure that basically minimizes the patient's breathing to just shallow breaths. By our ability to do that, we limit the amount of motion both externally and internally. We then put them into the CT mapping scan, essentially the same diagnostic CT scans you would have had that would have diagnosed your kidney tumor. We then capture the scans in 4 dimensions in real time. Basically, when we capture those images, we see it all the way through its entire maximal and minimal movement as the patient breathes. We then take those images to the computer system where then we design a specific and customized plan to every individual patient. We then take into account the amount or magnitude of motion when we define the target. The most critical target is what we call the gross tumor target, and then we add the margin to account for the movement during the breathing. Also, as importantly, we need to identify and contour and delineate all the adjacent normal tissues. While we strive as best we can to hit the target with as high a dose of radiation possible, the other goal is to make sure that the dose to the adjacent normal structures is as low and as minimal as possible to minimize any long-term or even short-term side effects over the course of treatment. We then proceed to a complex plan of computations and calculations to achieve the most sculpted radiation plan to that particular target for that particular patient. As you can see here on the right side of your screen, sometimes that could include 7 to 9 varying radiation beams in different geometries across the entire body, so that we are able to create that custom sculpted radiation plan. Whilst on the text, we have specific dose constraints and criteria that we must meet and cannot exceed to the adjacent normal tissues. This is all put through the computer system that calculates and does and meets our objectives in order to achieve what we call an optimal plan. At the time of treatment, we image in real time before, during, and after to make sure that we are on target. The picture on the left is the linear accelerator head, and orthogonal to that 90 degrees is a real-time imager. So it basically captures pictures before, during, and after the radiation treatment. And then at the time of delivery, we actually stop and check and then measure that we're actually, and visualize that we're actually hitting the target and that you haven't moved or the tumor is exactly in the same position at the time of the mapping scan to the time that the beam is actually on. You can see the 2 gray color washes. You can see the target highlighted in the light blue. And as you go across from the front, the side views and cross-sectional views, we can see that the kidneys match correctly, as is the tumor, which is highlighted in blue. Then we push the button. So this is a case to illustrate what I've mentioned to you previously. We have a very lovely 72-year-old lady that I met nearly 2 years ago who had severe respiratory disease. She previously had a heart attack. She had a very severe diabetes, long-term history of chronic renal failure. And unfortunately, in 2010, she was diagnosed with a biopsy-proven renal cell carcinoma of the left kidney that measured 3.5 to 4 centimeters. Unfortunately, she was not a candidate for radical resection due to her medical illnesses. As you can see in the bottom picture, on the cross-section, you can see a little bit highlighted in white with the red arrow. They tried to embolize, or basically starve or cut off the blood supply to the tumor. Unfortunately, that procedure was aborted and was not completed. Subsequent to that, in the next 6 to 12 months, the tumor grew. It increased to 5.5 to 6.2 centimeters in size. She saw the interventional radiologist and unfortunately was no longer a candidate for radiofrequency ablation, and she saw a nephrologist was on the verge of, or was actually on pre-dialysis. And that's when I met her. So we went ahead, went through the processes that I just described to plan and deliver a 5 treatment plan to target her left kidney tumor. As you can see, the target is highlighted in red. The margin that accounted for patient movement and setup error is in green. It's difficult to see, unfortunately, without an arrow, but the actual delivery or the dose of radiation should be red on red. And as you can see, it is a highly sculpted radiation dose. The red covers the red target, the green covers the green, and the doses of radiation as you move further away from the target are rapidly falling off, such that within a centimeter, the dose is 50% of what it is at the red target. The interesting innovation highlighted on this slide is, as you remember before, I said that we used to deliver treatments in 7 to 9 beams. Traditionally, that treatment time was anywhere from about 20 to 30 minutes. When I met this particular patient, we had already taken another step, another leap in our development technology. So instead of multiple beams, we're actually just doing a single arc in real-time delivery, such that we're able to cut down the delivery time from about 15 to 20 minutes to less than 5, so that when you take into account from the patient walking into the room, setting her back up on the vacuum blue bag, matching to the tattoos, taking the pictures, and doing the delivery, anywhere from 30 to 40 minutes, we were done over those 5 treatments, and she was finished within 10 days. So this is an example highlighting what we mentioned as how has the radiation worked. This is our first patient on our program. He was a 60-something-year-old gentleman who had diffuse multiple myeloma and once again had an enlarging, growing, and biopsy-proven left-sided renal cell carcinoma. His lesion measured at 4.5 centimeters at the time of diagnosis. After we treated him with 5 fractions of radiation treatment, the tumor appeared to have grown by half a centimeter, or 5 millimeters, at 3 months post-treatment. That's actually very, very common. It's something recognized, at least in the stereotactic brain literature, as what is known as pseudoprogression. The expansion and growth of the tumor is a result of the inflammatory reaction and edema and swelling as a result of the radiation. When we re-imaged him and followed him regularly every 3 to 6 months, by 18 months, the tumor had actually shrunk down to 3.9 centimeters in size, and he hasn't had any long-term sequelae or side effects from his treatment. So, what are the future directions with stereotactic radiotherapy for primary renal cell carcinoma? While I mentioned to you earlier that there is a growing body of literature and experience worldwide, the default, or how should I say, the disadvantages in that is that mainly those are case series or retrospective studies just based on single institutions. None of them are actually wide or large prospective studies. We had a meeting of the Genitourinary Radiation Oncologists of Canada in November, and we each recognized that the emergence of stereotactic radiotherapy for renal cell carcinoma requires further, more rigorous study. So we all agreed with 13 centers across Canada to put together and come together and complete and embark on a prospective trial to analyze the outcomes, quality of life, health utilities, and all other measures for primary renal cell carcinoma treatment with stereotactic radiation treatment. So I want to introduce another exciting event happening, and as Dr. Jewett and Dr. Berenson mentioned earlier, and that's the launch of a clinical trial led by Sunnybrook and a number of centers across Canada, and that is a phase 2 multi-center study including stereotactic radiotherapy for Oligo-progression and RCC patients receiving first-line Sutent therapy. Just a little bit about a background. This study is led by my colleague, Dr. Patrick Chung, and our esteemed colleague, Dr. Berenson, as well as my colleagues, Dr. Segal and Daniel Heng from Calgary. Historically and classically, cancer was either black or white. You either had localized or local regional disease, or it had spread, it was metastasized. There's really nothing in between. So you either had aggressive curative therapy if it was localized, or you were deemed palliative because it had traveled to other parts of the body. As we know, as you all know, that's not the case. Since 1995, the paradigm or definition or the term oligometastasis has gained greater traction. And what that's really defining is that cancer is not just a 1 or 0 state of either you have it localized or travel to other parts of the body. It's really a spectrum of disease and then all the way in between. So oligometastases is really a limited number of metastases in number and location that could potentially be eradicated with local therapy. This localized sites of disease could either come de novo, just based on the specific patient's biology, or via treatment of a successful systemic treatment like our targeted therapies for renal cell carcinoma. The treatment of oligometastases was first pioneered by our surgical colleagues, for example, like in colorectal cancer, metastectomy, surgical resection of liver metastases actually can potentially translate to 10, 20 years of long-term survival. And in terms of the radiation oncology field, the development and the technical advancements allowing us to deliver focal ablative radiation has really allowed us to achieve excellent local control, and we've actually been able to been seeing more referrals from our colleagues for the treatment of oligometastases across different body sites. What we do know is that stereotactic body radiation leads to excellent control with very minimal side effects. So I've defined for what oligometastases are. That refers to the state or the spectrum where it's a spectrum between localized versus diffuse disease, and generally limited in number, generally less than or equal to 5. For the purposes of the study, what does oligo-progression mean? It means individuals who have oligometastatic disease, however, who are progressing in 1 to 5 areas, meaning the tumors that have metastasized, those which are only growing, while the remainder of them remain under control. So the primary goal and outcome is to try to maintain or attempt to maintain these patients on first-line Sutent and basically deliver stereotactic radiotherapy to those particular lesions that are growing or changing in size. The primary outcome for this is basically local control. To those sites of tumor, are we able to control them and measure that outcome? And our initial sample size is 64 patients. And the study will be opening soon. Perhaps Dr. Berenson can give us a specific target start date. So I've highlighted some of the changes and evolving roles of stereotactic radiation, both for primary and oligometastatic and oligoprogressive renal cell carcinoma. We at Sunnybrook are really taking advantage of the multidisciplinary care and really having individuals like Dr. Berenson, who's a thought leader in the management of renal cell carcinoma, and bringing us radiation oncologists into the fold to really bring to light the whole concept of multidisciplinary care has been really, really important for us and is really changing the paradigm of treatment of renal cell carcinoma. Individuals like our colleagues in radiology or diagnostic imaging, as you heard from Dr. Berenson, is really allowing us to basically measure responses to drug therapy and also to radiation therapy. But furthermore, right at the point of diagnosis, new and evolving sequences in MRI will allow us to basically tease out the radiologic characteristics and give us a hint on the biology of the tumors, such as the ones that are small, but those who are at highest risk of developing aggressive or distant disease. I want to give thanks to my colleagues. Stereotactic radiotherapy is not a very simple, traditional, two-dimensional treatment plan. It's highly advanced with lots of complex computations, as you saw. I have to give thanks to my colleagues who treat multiple organ sites that include the lung, the liver, the spine, as well as our medical physics colleagues that do all the hardware and computations. And we're also very fortunate at Sunnybrook that we have the only one in Canada, and that's Ms. Darby Earle. She's the SBRT specialist radiation therapist that actually meets our patients from day one and essentially navigates them all the way through and beyond their journey for stereotactic radiation. Thank you.